So hello MDS aspirants, once again welcome you all to Sail to MDS Dental Academy. Myself Dr. Malay Trivedi, I am pediatric dentist and assistant professor in College of Dental Sciences. So dear friends, today we are here with one more YouTube premier lecture. I am live there. You can ask your doubts on the chat box open. So friends, today we are going with the part 2, that is platelets and its disorders and drug used in hematology. So this is our PPM series. It means one of the interactive way of my academy to teach physiology, pharmacology and medicine. So dear friends, in part 1 what all we have discussed? We have discussed about the functional anatomy and physiology of blood. Then we have discussed about the RBC, hemoglobin, then iron metabolism, what all the disorders associated with RBC. Then we have seen WBC, its function, its associated disorders, and at the end I have provided few mnemonics and one clinical anatomy chart I have provided, in which almost all the signs and symptoms of your any blood disorder come. So I request all to see that chart so you can answer any of your case based question. If you have not seen, the information is there in the description box, and also you can click on the I button given above. So friends, I am assured that after watching this video you all will be thorough with your platelets, will be thorough with your thrombus formation, embolism, what all drugs come in the hematology. So just carefully hear it and try to understand. Before that, a small announcement that from May 10th we are starting our new batch series, the second batch of this year. In that we have around 55 lectures covering subjects for 2 to 3 times, and the lecture is such that you can save it and access at any time. We are working on concept based learning. Surely at the same time you have some special feature, like somebody is weak in any anatomy, they can select single subject or they can select a group of subject. And we have revised our fee structure because of COVID-19 situation. So friends, the information regarding schedule is there in description box, and if you want more details you can contact me, the information is there. So let's get start with the video. So as everybody know what platelet will do, I have told in my first video the platelet will stop bleeding. The common thing, it will stop bleeding in your body. Fine. So how that bleeding will stop? So there are two processes involved, that is your hemostatic process and fibrinolytic mechanism. Fine. So what is hemostasis? It means stoppage of bleeding. So imagine in your body anywhere bleeding is there, so hemostatic process came into picture. So what it will happen? So first what will happen? The vasoconstriction will happen. It means your blood vessel only will reduce the blood flow. Fine. Second, the platelet come into picture. That is your primary hemostatic mechanism. What platelet will do? It will try to form the initial plug by its adhesion and by its aggregation. After that, we require some stable thing not to allow the bleeding to occur. So for that, the clot formation take place. Remember, the important step in clot formation, that is your intrinsic, extrinsic and common pathway, is the activation of thrombin, because that will convert fibrinogen into fibrin, and your fibrin is known as stable clot, one of the very important MCQ. Fine dear friends, so in this way the bleeding will stop in your body. Now imagine that in your body somewhere bleeding has occurred, the clot has formed, but this clot should not stay forever in your body. Okay, it has to be lysed, it has to be break down. So now the fibrinolytic mechanism come into picture. So always remember, we have two processes, hemostatic and fibrinolytic. Now we see in this diagram. So this diagram is very important. We can cover almost 5 to 6 major MCQs. Now as I have told you, bleeding occur. So first thing is vasoconstriction. Second thing is your platelet activation. So remember, this is your primary hemostasis. So whenever in exam question is there about primary hemostasis, the platelet plug come into picture. And to activate this platelet, this two things is required, that is von Willebrand factor and fibrinogen. Remember dear friends. Fine. And coagulation, I have told the thrombin is required for the formation of stable fibrin clot. Now to lyse that clot, plasmin is required. Fine. And this is your secondary hemostatic mechanism. Okay dear friends, so important question you remember, the question about the plasmin, about the thrombin, about your VWF and fibrinogen, about primary hemostasis and secondary hemostasis. Fine, dear friends, so let's get to the pathological or medicinal aspect. Now imagine that in your body the bleeding or this coagulation and the hemostatic mechanism is occurring properly. Now imagine that this hemostatic process are inactivated at any time, anywhere. You can say inappropriately. Then what will happen? Thrombosis will happen. You know thrombosis is a formation of clot at various places in the body. And if that happens, the blood flow will hamper. Okay, so let's remember the simple mnemonics, that is thrombosis occur at PM. Okay, so A stand for atrial fibrillation, T stand for thrombosis, deep vein thrombosis, P stand for pulmonary embolus, and M stand for myocardial infarction. Most commonly in these disorders we can see thrombosis. And if thrombosis occur, it means everywhere the clot is getting formed in the body. So this is your thrombosis pathogenesis, or we can say pathophysiology. Fine, dear friends, hope you understand. Now let's come. Now imagine your hemostatic mechanism is not occurring properly and thrombosis occur. Then what will happen? We have to provide few drugs, that is your anticoagulant, antiplatelet, and fibrinolytic agents, which keep balance between your clotting and bleeding. So this is way how, if disease occur like your myocardial infarction, how we prevent thrombosis to occur at various sites in the body. So let's see little pathology also, that how thrombus will get formed. So remember, dear friend, thrombus is a type of blood clot only. There are two types, that is arterial thrombus and venous thrombus. Fine. Now we'll see each thrombus, and also we'll see that how the thrombus get formed. Like remember, dear friends, arterial thrombus is formed by platelets, and most commonly what happens in your body, annual atherosclerosis is occurring, means thickening of your vessels, and if it get ruptures, your arterial thrombus will form. Fine. And remember the treatment of arterial thrombus, as it is formed by platelets, the treatment is antiplatelet drugs. Okay, so whenever you see question of the thrombus, arterial thrombus, just write the antiplatelet drugs. Fine. So you can see in this diagram the thrombus in your coronary artery. Fine. Now let's see venous thrombus. It is formed by your RBCs and platelets. And always remember that this venous thrombus only give rise to embolism. Embolism means what? Your thrombus will detach from the site and it will move in the body, and it will create embolism at any place. So that is your embolism. But only venous thrombosis give rise to embolism. Fine. And it is treated by anticoagulant drugs. Okay, so you can see in this diagram how your venous thrombosis occurs, and this is classical picture of pulmonary artery of forming thromboembolism. Well done. So we have seen how your arterial thrombus occur and venous thrombosis occur, and we have seen what all they contained and what all their treatments. So now let's come to the pharmacological aspect, that is drugs and blood clotting. Now imagine that in your body the improper clotting is formed. So what we have to do? Let's come to the basic physiology. We have to have a drug which act on the primary hemostatic, secondary hemostatic, and this fibrinolysis area. So for this primary hemostasis we have antiplatelet drugs. For secondary hemostasis we have the anticoagulants to act on the coagulation pathway, and third we have antifibrinolytic drugs. So I hope it's not need to mug up, you can easily remember. So what are anticoagulants? They just modify your blood clotting mechanism. Antiplatelet, they inhibit COX-1 activity. And what is fibrinolytic? They break down fibrin. So example, I have not given many example here, we will see later, but to remember that heparin and oral anticoagulants. It means heparin cannot be given orally. That's why I have separately written oral anticoagulants. Antiplatelet, we have aspirin, and mostly that is clopidogrel also. And for fibrinolytic, one of the example is your Antiplatelet. Fine. So these are few drugs which help in prevent or reverse your thrombus formation. So friends, now let's see what are type of anticoagulants. So here also I have made one simple mnemonics how to sell DT. H stands for heparin. We have two type of heparin, high molecular and low molecular weight heparin. Remember, your low molecular weight heparin act very fast. Then second comes your W, that is warfarin. Then there is cell, that is selective factor 10A inhibitors, and we have DT, that is direct thrombin inhibitors. So these are four main classes of your anticoagulant drugs. So let's see about the heparin. So I hope in pharmacology everybody knowing the word pharmacodynamics and pharmacokinetics. Very simple. Pharmacodynamics, D. It means what? What the drug will do to your body. And what is pharmacokinetics? What the body will do to your drugs. That is the difference between pharmacodynamics and pharmacokinetics. So what is heparin, dear friend? It is your sulfated mucopolysaccharides. Fine. And most commonly it comes in high and low molecular weight ranging from 3000 to 30,000. It commonly acts at 83, that is it inhibit thrombin. So we can see in this diagram, this is your common blood clotting mechanism. I will repeat this 3 to 4 times in my slide so everybody can remember. We have extrinsic pathway where factor 8 is there. We have intrinsic pathway where factor 12, 11 and 9 is there. When these two come in picture, they activate common pathway, that is activation of factor 10A, which will convert your prothrombin into thrombin, and this thrombin will help in conversion of your fibrinogen into fibrin, which stabilized fibrin. Fine. So in this manner your extrinsic, intrinsic and common pathway will help in coagulation. So now see where all your heparin is acting. Remember, heparin is acting everywhere in your intrinsic pathway only. Fine. So remember, it is acting from your first to last step, that is up to thrombin it is acting. Okay, so you can say heparin is your versatile anticoagulants. Fine. So let's talk about now low molecular weight hemoglobin. The best example is enoxaparin. Fine. They have more consistent activity than your high molecular weight heparin. Remember, this low molecular weight mostly act on factor 10A and thrombin, and they have immediate action. Now you can see in this diagram where your high molecular weight heparin is acting everywhere, but your low molecular weight is acting only on the 10A factor. Means it is acting on the common pathway only. So sometime when you require a rapid action, we give to the patient low molecular weight hemoglobin. Fine. So always I told heparin cannot be given orally because it is not absorbed from GI tract. It can be given IV or subcutaneously. Your low molecular weight is given subcutaneously only. Half-life very simple to remember, 1 to 2 hours. It is given as continuous infusion and maximum once in a day you can give to your patient. Remember, it is excreted by a renal mechanism. So whenever you are giving to patient having renal disorder, you have to take care. And whenever there is an overdose of heparin, we have to treat by IV protamine sulfate. Fine. This is the antidote for your heparin. Okay, it's just a simple protein. Fine, dear friends. So where all you use heparin? So heparin you will use to treat your venous thromboembolism. So anywhere occurring venous thromboembolism because of your post operative, like you have treat your bypass surgery has been done, or patient is having angina or myocardial infarction, to prevent venous thromboembolism, we give heparin. Now how we give heparin? Now imagine that if patient require a anticoagulant for a period of 7 to 10 days, so we cannot give oral anticoagulant because it will not act that much fast. So the medicine people give heparin initially to start the anticoagulation therapy, and after that they stop and they continue with the oral anticoagulant drugs. So heparin act as the starting drug, and to continue we use oral anticoagulant. So friend, these are the few points for your heparin and low molecular weight heparin. I hope you have understood where it is acting and how we deliver it to the patient. So now, dear friends, we will see about the oral anticoagulants. We have seen the anticoagulants which we give IV and subcutaneously, that is your heparin and low molecular weight heparin. So as I have told, in the initial stage of your treatment we give IV drugs followed by the oral drugs. So before that we need to understand about the vitamin K cycle. So remember, very important MCQ, that vitamin K help in the activation of your clotting factors like 2, 7, 9 and 10. Okay, and to maintain the vitamin K levels in the body, vitamin K reductase enzyme is most required. Okay, so remember that, so whenever you want the clotting factors not to get activated like 2, 7, 9 and 10, we have to work something on vitamin K reductase. And also remember, dear friends, whenever you are extracting natal teeth or neonatal teeth, the history that patient have taken vitamin K at the birth or not is the most important. So now let's talk about the drug Warfarin. It is an oral anticoagulant drug. So remember, it acts on the vitamin K reductase. So now everybody can remember that Warfarin act on the vitamin K reductase. Why? Because we don't want the activation of factor 2, 7, 9 and 10. So now let's talk about the coagulation pathway. Again, there are two: extrinsic, intrinsic pathway. Extrinsic we have factor 8, intrinsic we have 9, 11 and 12. Common pathway we have factor number 10, thrombin and fibrin. Okay, so where your warfarin is acting? Your warfarin will act on the extrinsic pathway. Remember, your heparin was acting only on the intrinsic and common pathway, where your warfarin can act on the extrinsic pathway, intrinsic pathway as well as on the common pathway. So it is one of the gold standard drugs for the anticoagulant therapy. Now let's talk about few clinical use of your warfarin. It can be used to prevent the progression or your recurrence of venous thrombosis, pulmonary embolism. You can see in the diagram, the beautiful diagrams are there. It can also use to prevent arterial thromboemboli in patients having atrial fibrillation or any kind of valvular heart disease. Now comes the treatment duration. So whenever you give anticoagulants, at least 6 weeks to 3 months we have to give. 6 weeks for your calf vein thrombosis and 3 months for your deep vein thrombosis or pulmonary embolism. It is one of the important questions when they ask the duration of your anticoagulant drug. It is between 6 weeks to 3 months. 3 months for your DVT and PE. Now let's talk about how to give such drugs. Fine. So as I have told you that you start the treatment with heparin and continue with the oral anticoagulant, most commonly warfarin. Now if we give the patient heparin, okay, why we give? Because it is rapidly active. So when we give heparin, we have to monitor the heparin levels. We monitor with the help of APTT, that is activated partial thromboplastin time. Most commonly they are asking the exam how to monitor heparin, or when we give heparin which time will increase or decrease, that is your APTT. Now when you give low molecular weight heparin, there is no need to monitor because they have very less side effects and very few bleeding complication. Fine. So that was about your heparin. Now when you give warfarin for several days, what you have to monitor? You have to monitor the PT time, that is prothrombin time. Fine. And also one important thing, your PT time is also used to monitor extrinsic pathway. Fine. And whenever there is a overdose because of heparin, we give IV protamine sulfate, and when there is overdose of warfarin, we have to give first fresh frozen plasma. Why? Because they have clotting factors. But specific drug for the warfarin overdose is vitamin K1. Fine. And nowadays we use INR, that is International Normalized Ratio, to monitor the warfarin level. And in this we use the prothrombin time of patient, prothrombin time of reference, along with ISI, that is International Sensitivity Index. So dear friends, we have one good chart and I want everybody to remember this because it is one of the important. They have asked around 5 to 6 times in the examination. So whenever the INR value is less than 5, we discontinue warfarin temporarily and restart at lower dose. Fine. If there is 5 to 9, we give vitamin K1 around 1 milligram. If it is more than 9, we give vitamin K1 around 2 to 3 milligram. And if it is more than 20, or patient is having more bleeding, we give fresh frozen plasma. So this is the way how you manage your warfarin overdose. So now dear friends, let's talk about few questions. Now imagine that patient is taking warfarin or he is taking some other drugs. Then what will help to the coagulation mechanism in your body? So we'll talk about four important questions which are very important for your exam point of view also, that if drugs which have a high affinity for the plasma binding protein albumin like sulfonamides, then what will happen to the anticoagulation? If you are giving the drugs which reduce absorption of your warfarin like sucralfate, what will happen? If you are giving the drugs like aspirin which will decrease platelet aggregation, then what to do? And if you are giving the drugs which inhibit cytochrome P2C9, then what to do? So these are good four questions. We'll see each question one by one. So now few warfarin prescribing questions. Now imagine that you have prescribed your patient warfarin, and along with that the patient is taking another drugs or another therapy is ongoing. Then what will happen to that anticoagulation mechanism in the body is very important. So as I have told, I have jotted down four important questions. Please understand it, very important for your NEET and AIIMS exam. Now imagine that you are giving a drug which have high affinity for your plasma binding protein albumin. We have talked about plasma binding protein last lecture. You can see that. So remember that your warfarin also have a high plasma protein binding ability. And if you are giving drugs like sulfonamide who have same thing, then what will happen? Your anticoagulation will increase or decrease? Definitely it will increase, because as I have told, both will compete with albumin. So more warfarin will be available, and so more warfarin will be there, more its action will be there, and its action is anticoagulation. Now imagine if you are giving a drug like sucralfate. Normally we give sucralfate in case of GERD and as an antacids. So this drug will reduce absorption of warfarin. Then what will happen? The anticoagulation will automatically decrease, because less warfarin will be absorbed from the GI tract. Okay. Now you are giving a drug which decrease platelet aggregation like aspirin. Okay. So now already in body aspirin is there, and you are giving warfarin also. So both have same action, that is anticoagulation. So what will happen? The warfarin action will increase, and anticoagulation in your body will also increase. Fine. So that's why when we go for the extraction, we always ask the patient whether they are taking aspirin or not. Now let's see the one more point, that is drugs which inhibit cytochrome P2C9. Okay. What is this cytochrome P2C9? It will inactivate or it will metabolize your warfarin. So now you give certain drugs like a St. John wort which will inhibit CYP2C9. Then what will happen? More warfarin will be available because it will not get metabolized, and in this way your anticoagulation will increase. And this St. John wort is important MCQ. It is a oil which we give to the patient in case of anti-anxiety treatment, because it helps in release of serotonin. So we have seen all the four questions here. You are giving drug which have high affinity for PPB. You are giving drug which reduce warfarin absorption. If you are giving drug which have same action like warfarin, or some drugs which inhibit CYP2C9. So if you see all these four questions, definitely any question in the exam you can answer. Okay, I hope you have understood. Now let's talk about newer oral anticoagulants. So we have seen heparin, low molecular weight heparin, warfarin. All these things have certain side effect. Now let's talk about newer drugs. That is selective factor 10A inhibitors. Means it will act directly on the common pathway. Or we can see the direct thrombin inhibitor. So it will act directly on the thrombin, like your dabigatran. Fine. So where you use your dabigatran? Mostly for the prevention of stroke and in embolism patient, and also as a prophylactic drug after hip or knee replacement surgery. And there is no need to monitor this newer oral anticoagulants. Fine. So as I have told you, your dabigatran will directly act on your thrombin. So no coagulation will take place. Fine. So now we'll talk about the antiplatelet agents and thrombolytic agents. So as we have seen, what your platelet will do, it will help in primary hemostatic mechanism by platelet adhesion, platelet activation and platelet aggregation. In this platelet aggregation, remember this enzyme, that is thromboxane A2. Now the best example for your antiplatelet drug is your aspirin. Okay, so what will happen, there is one metabolism, one pathway will occur, and when thromboxane A2 will get activated, it will help in activation of the platelet. It will convert your resting platelet into the activated platelet. So we need to halt this pathway, and there is enzyme responsible for this pathway is COX-1. So as we know, what is the best drug? That is your aspirin drugs, because aspirin helps in COX-1 inhibition. So the pathway will not occur, and if thromboxane A2 will not form, your platelet is not going to get activated. Most commonly it is used as a prophylactic to prevent arterial thrombosis, like in case of your transient ischemic attack, in stroke, and in case of myocardial infarction. And remember, whenever any patient is taking aspirin and you are going for extraction or any surgery for in your oral cavity, the platelet inhibition is irreversible and it will effective for around 7 to 10 days. So after the stoppage of aspirin, after 7 to 10 days only, you can go for your surgical therapy. Okay, now let's talk about fibrinolytic drugs. So as we know that if imagine the clotting, hemostasis has occurred, clotting has occurred. To maintain that clot, we require some stable clot, that is your fibrin, and for that the plasmin is so much important. Okay, because this plasmin will only convert fibrinogen into fibrin. So we have three fibrinolytic or thrombolytic drugs, that is streptokinase, alteplase and urokinase. Okay, this will not allow the stable fibrin clot to form. Normally we give IV, they have immediate effects, but they are very short half-life, that is 10 to 90 minutes, and the main hazard is bleeding. You can see here, if untreated patient, your plug will be formed. After you treat with plasminogen activator, the bleeding can occur. So main use nowadays for restoring catheter and shunt function by lysing clot that causing occlusion, and to dissolve clot that results in strokes. Fine dear friends, so we have seen almost what all we have seen, just we have quick revision. So first we have seen about how the clotting mechanism take place, all the hemostatic and fibrinolytic mechanism. Then we have seen about the heparin, low molecular weight heparin. Then we come to oral anticoagulant. We have seen vitamin K cycle, warfarin we have seen. Then we have seen newer anticoagulant drugs. Then at the end we have seen antiplatelets and thrombolytic agents. So friend, that was all for the today lecture. Any doubt you have, you can ask me in the live chat box open. And please dear friends, work hard. And yet I have seen many students are asking me few questions regarding how to prepare all that. You can ask me, no problem. But 2 quick videos I am showing on the screen. You can click and you can revise those points, and then if any doubt you can ask me. Thank you all for patient hearing.